Avem aici invitata noastră specială, profesora Dronca, de la Mayo Clinic din Jacksonville. Profesora Dronca este specialistă în melanom și a condus studii absolut care au schimbat peisajul tratamentului melanomului și astăzi o să ne vorbească despre melanom.
Mulțumesc mult, Doru. Ești prea generos cu introducerea și îmi pare foarte bine să fiu aici. O să vorbesc un pic despre melanomul cutanat. Nu cred că avem destul timp să vorbim și de celelalte forme de melanom, dar aș fi bucuroasă să particip din nou în altă dată. Eu o să vorbesc în engleză pentru că sunt un pic mai cursivă în limbajul medical în engleză. Okay, so as I mentioned, we'll chat a little bit today about malignant melanoma and focusing on skin melanoma. These are my disclosure, which I think matter in US. So what is melanoma? Well, melanoma is, as you probably all know, a cancer of melanocytes, so pigmented producing cells. The most common form of melanoma starts in the skin, where it can actually show up either as a pigmented or a non-pigmented lesion. Approximately 30% of melanomas are not pigmented, flesh-colored papules, which are extremely hard to diagnose. Even experienced dermatologists have difficulty diagnosing it, and a lot of times these become apparent when they start changing, bleeding, crusting, and or when they metastasize. As I mentioned, melanoma can also start in the eye, which is called uveal or ocular melanoma, and melanoma can also start on mucosal surfaces. These last two are much less common than cutaneous melanoma, but they are much more difficult to treat. Ocular melanoma, I'll just say this, has a completely different immunological as well as genetic profile, and really doesn't respond to the same treatments like cutaneous melanoma is. And mucosal melanomas, while they resemble a little bit more the skin melanoma, they still have a much lower response rate to the immunotherapies that we use now in cutaneous. So most melanomas, not all, as you will see in a minute, are environmentally induced. And the main risk factor for melanoma, of course, is UV radiation. You see here the two forms of UV rays. UVA is the deeper, actually, UV ray, but it causes mainly your squamous cell, basal cell carcinoma, actinic keratosis, or sunspots, as we call them. Less, commonly, but it still can be a risk factor for melanoma. The risk factor for melanoma, though, are the UVB rays, and these are the ones that are more responsible for the skin burns that in the end, can be a major contributor to development of melanoma. The reason I'm telling you this is that it took me a while to kind of understand why the sunscreens need to be, or how you counsel your patients to look at sunscreens that cover both UVA and UVB rays. For a long time in US, a lot of the sunscreens actually only covered UVA rays, and I see in Europe there are still a lot of sunscreens that are UVA based. Those will address your squamous cell, basal cells, but may not necessarily protect patients from melanoma. So you gotta tell patients you need to buy either it says complete sunscreen or it says UVA and UVB sunscreen. Risk factors, as you see here, a number, so patients who are more prone to developing melanoma are, of course, those who have more fair skin, who have blue eyes, red hair, lots of freckles. Intermittent and intense sun exposure is a very big risk factor for melanoma. So for instance, here in the US, in the northern states, Minnesota and North Dakota, etc., there is a very high rate or incidence of melanoma because people in Minnesota are usually the Northern European descent. So those people with very fair skin, freckles, they have sun very, 4 months a year, and they are exposed when there is sun outside, everybody's outside, not necessarily thinking about protection. And that predisposes people to an intense, short-lived sun exposure in a predisposed individual, and that increases the risk of melanoma. If one has had multiple life burns in their lifetime, there may be a risk of melanoma later in life, as well as people with a history of atypical moles or a lot of moles, as well as first-degree relatives of patients with melanoma. Only about 5% of melanomas have a genetic predisposition where we can, really find one of these genes predisposing to risk factors for melanoma and other cancers through germline testing. Immune suppression is also a risk factor for melanoma, organ transplant recipients, or patients on chronic immune suppression. Melanomas appear, there is a little bit of a different distribution in males and females. Males tend to develop melanoma mainly on their trunk, and women have an equal distribution on the trunk and the legs. For men also, there is a much higher rate of melanoma on the head and neck area, especially scalp, ears, nose. The scalp melanoma, ear melanomas are a lot more, difficult to treat, and they have a predisposition to recur. So these melanomas really need to be, very aggressively monitored and treated. A number of this is just to show you how, a melanoma lesion can evolve. And while we are not dermatologists or doing dermatoscopy, we really need to be able to recognize and or counsel our patients, know when to refer them back to a dermatologist. The 4 signs, A, B, C, and D, the asymmetry, when they become irregular border, they have colors, that within the same mole, different shades of brown and red, as well as when the lesions enlarge more than 6 millimeters in diameter, usually those become very suspicious. But the main characteristic for a lesion that is suspicious is actually a lesion that is changing. Patients will come to you and they will say, I know I've had this mole forever, but now it looks different. It looks like it's more raised, it started bleeding, or now it looks like it has different colors. That's an absolute, danger sign. So patients need to be seen very quickly by dermatologists who will do a full skin exam as well as the dermatoscopy exam. Now there are different techniques on how you can actually do whole body photography and analyze these lesions, or analyze sequentially if these lesions have changed. Even if a dermatologist suspects a lesion or doesn't, the actual ultimate diagnosis is, as you know, by biopsy. We really discourage shave biopsies. And again, we're not dermatologists, but we need to know as oncologists what to tell or how to talk to our dermatology friends. A shave biopsy, as we will see when we look at the staging of melanoma, will only take the top part of the lesion, and we will never be able to fully assess the breast load depth. And I'll explain that in a second. So we really want patients to have punch or excisional biopsies to be able to capture, if possible, the whole depth of the lesion. The subtypes of cutaneous melanoma can be, as I mentioned, sun-induced or not sun-induced. So a number of the chronically sun-induced melanomas are the ones who appear on the sun-exposed areas, as we talked, but they are less likely to carry the BRAF mutation. The ones that are appearing on the non-sun exposed areas have the highest proportion of BRAF mutation. Most of you probably know already about BRAF mutation. This is a mutation that actually predisposes, cells to proliferation and metastasis, kind of independent of environmental risk factors. Acral melanomas are the ones that appear on the soles, palms, or under the nails. as well as ears and scalp. Those mainly carry a different type of mutation. On BRAF, they mainly carry a KIT mutation. Also, melanomas, 90% of melanomas appear on or are Caucasian population is actually the one that carries the main burden for most melanomas, 90% or more. But we do see melanomas in other races and ethnicities. We do see melanomas in African American patients. I do have a number of patients in my practice, African American with melanoma. Usually you will see those acral melanomas on the feet, fingers, under the nails, as well as scalp. We talked a little bit about mutations. So BRAF mutation is usually kind of roughly responsible or present in about 50% of melanomas overall, mainly again in those arising on the skin without chronic damage. 50% is kind of a general, how you assess if melanomas or if a patient is more or less likely to have a BRAF mutation. One is where it appears, but two is also age. BRAF mutated melanomas tend to appear more in young patients and are less frequent in the older population. So I've learned a while ago, and I still kind of apply this in my mind. The risk of having a BRAF mutation is roughly 100 minus age. So if you have a 20-year-old patient with melanoma, the probability of having a BRAF mutation is 70 to 80%. If you have an 80-year-old patient with melanoma, it is quite unlikely to find a BRAF mutation. Again, the likelihood is much lower. The ones arising from skin with chronic sun damage don't have a lot of mutations. Only about 10% are BRAF positive and about 10% NRAS positive. The ones arising on the skin with chronic sun damage, though, have usually a very high tumor mutation burden. We know that environmental induced cancers, head and neck, melanoma, squamous cell carcinomas usually have a high tumor mutation burden, which is one of the biomarkers that we think potentially can predict response to immunotherapy. Mucosal melanomas carry about 20% KIT mutation and almost equal NRAS mutations, and the acral melanomas are pretty similar. As I mentioned initially, uveal melanoma, very different mutational landscape. They are GNA11 and GNAC, usually positive and very unlikely to find a BRAF mutation. I'm just going to mention here, even though we're not going to talk about the mucosals and or acral melanomas too much, but even though they carry a KIT mutation, we use and we try targeted therapy, with these tumors, but they do not respond as well to your, targeted therapy as other tumors with KIT mutation. So while we can try, it's unlikely to have a long-term and a robust response. The staging of melanoma, we look at three things. That's what I tell my patients. We look at the depth of the tumor or the characteristics of the primary tumor, the lymph nodes involved with melanoma, and the metastasis. And the combination of these three gives the stage. So in terms of the tumor, as you see here, we look at the Breslow depth in the skin, and that is measured in millimeters. In the past, we used to look a lot at the Clark level of the skin, 1, 2, 3, 4, or 5. And while that's still, pathologists will still use this, it doesn't really help in the actual staging, as you will see, because a lot of times the Clark level correlates with the actual, depth, but what we need to know for sure is the Breslow depth in millimeters. Also, as you see in this picture, if one does a shave biopsy, it will remove probably the top of the tumor. But with the biopsy, the layers of the skin will shift. So when you do then the wide local excision later to remove the entire melanoma, you can never tell if those things were stacked, upon each other, or whether now the layers have shifted and you took a part of the tumor and then the other was, kind of arranged differently, so you cannot add the two. So you will never know the the true depth, you will have to take the biggest depth, whether it's from the first biopsy or the second. So that's why we discourage really shaped biopsies where you don't have the entire specimen. We also look at the mitotic rate, which is the number of cells that are actually dividing in on the high power fields. And on 10 power fields, the pathologists give us the mutation rate. Anything more than 0, it's a higher mutation rate, but usually the ones who are 5, 6, 7, 10, mutations per high power field, those are kind of melanomas that are more aggressive or more rapidly growing. And there is a little bit of a correlation, with prognosis. In 2018, the AJCC classification has changed for melanoma, and a number of things have changed significantly. And it took us a while to kind of relearn and re-register how we stage these patients. And I'll show you in a minute, especially this is for stage 3. So the tumor, as we mentioned, is the Breslow depth in millimeters, T1, 2, 3, and 4. And another important characteristic is skin ulceration at the top. Melanomas that have ulceration behave a little bit more aggressive than the ones without, and are usually it upstages kind of one stage if you have a T1B or a T2B versus a T2A. So it is very important that the pathologist tells us that in their report. Lymph nodes are, characterized whether it's a clinically occult lymph node, meaning that lymph node was diagnosed with melanoma in it based on a sentinel lymph node biopsy that the pathologist removed and saw melanoma cells, or whether it was a clinically apparent node, either on palpation or physical exam or on imaging. If they are clinically detected, again, they get a higher grade, right? They are N1B as opposed to N1A clinically occult. What changed in 2018 is also that the presence of any number of satellites. Now it is considered equivalent of a lymph node disease. And you see, here, presence of its satellite or microsatellites. If a patient has no lymph nodes, but has a satellite lesion, it's considered an N1 lesion. So it's the same, like they would have a lymph node involved. What are satellite lesions in melanoma? Melanomas like to march towards the regional lymph node basin. They start on the skin, placed on the skin, and then what they want to do is to get to the lymph node. So they start traveling through the lymphatics, and that's basically the equivalent of a lymph node disease. So your satellite, lesions are considered lymphatic spread. If you have, 2 nodes or 1 node, you are N2, or if you have 1 node and satellites, again, you're upstaged as an N1C. The other thing that was different in 2018 is that now we have the M1D disease, which is presence of brain metastasis. And, the rest M1A is when people have skin and soft tissue metastasis only, as well as lung is M1B, and the presence of distant metastases that are not lung or skin is M1C. So as I mentioned, the reason it's important to know this is because this has changed, especially how we stage stage 3 melanomas. This is showing stages based on the tumor as well as the lymph node. And as I mentioned initially, if you have a T1A lesion, you're a stage 1A. If you have a T1B lesion, which is the same Breslow depth, but now it's ulcerated, you're upstaged as a 1B. And this, kind of holds true for the rest. The important thing about stage 3 is that before AJCC 8, for instance, anybody who had N1A disease all the way to 4A, they were staged as 3A. Now, 3A is only like a small subcategory of patients. If you have a very thin melanoma, non-ulcerated mainly, you are a 3A. If you have an ulcerated or a deeper melanoma, you're automatically a 3B. And what is most, or what changed the most, is that you may have a microscopically involved node, but if you have a deep ulcerated tumor, you're a stage 3C disease. And now we have the stage 3D, which is even more aggressive. It's your N3 patients with a T4B. T4B are lesions more than 4 millimeters and ulcerated. Why do we care? Well, we care because the stage really associates with prognosis. As you know, you see here, let's look at stage 3. 3As do quite well, right? The risk of, or like the melanoma specific survival for a 3A is 93% at 5 years and 88% at 10 years. So the risk of dying for melanoma with a 3A at 10 years is like 12%. But if, as we mentioned, in the previous thing, if you're a 3B or a 3C with just again one lymph node, but a deeper tumor, the difference, look at the difference on a stage 3C melanoma specific survival. Your risk of dying from melanoma is 40% compared to 12% with one same lymph node, but with deeper tumors. So it's really important to stage the patients. And I still look every time when I get the pathology report just to make sure, I still look exactly, especially for stage 3C, which substage you are, because it makes a huge difference. Stage 3Ds are basically, I consider them stage 4 waiting to happen. These people will, recur and become clinically apparent within the first couple of years, usually, and kind of same holds true for 3C, a really high risk. Now, if you look at stages 1A, B, and 2s, you see that most patients here have a very good prognosis, especially, you're up to 2A. Again, the melanoma specific survival is in the upper 80s and 90s. But if you start, in the 2B and 2C stage, again, deeper ulcerated lesions, you significantly drop almost stage 2C, if you see here, have a melanoma specific survival that is lower even than stage 3As. So when I advise, and we will talk about, adjuvant therapy, I really pay attention to the stage 2C patients, because these can be actually much more aggressive and relapse more than stage 3As. So how do we work up these patients? If you have, again, a stage 1 and 2 patients, so maybe except, 2C here, and still debatable in the guidelines what we should do in terms of workup. But as you see, they are more aggressive. But in general, the guidelines or the kind of clinical practices to not do laboratory work and imaging, especially for stage 1 and 2A patients, because the yield of finding something is very low. Now, in stage 3, you start having a risk of metastasis that is much more, kind of palpable, right? If you have a sentinel lymph node positive node, which means you diagnose melanoma in a node after sentinel lymph node biopsy, you do have a risk of finding other metastases, which is, up to 5% probably, or even a little bit more, depending on the depth of the tumor. If you have a clinically positive node, so patients show up with a node that you can feel and or you see on the PET, the risk of metastasis is higher. So for these patients, we want to do further imaging. PET scan is preferred, and in my opinion, I also like PET scan for melanoma, because again, melanomas of the extremities that will have satellite lesion, etc., you cannot really assess with a CT chest, abdomen, pelvis. So PET scan is preferred here in US. Most insurance companies will approve a PET scan in the workup of melanoma. If you don't have a PET scan available, absolutely a CT chest, abdomen, and pelvis, or include the neck if for head and neck melanoma is acceptable. For all my stage 3s, especially 3B, 3C, and 3Ds, I complete the staging with an MRI of the head, because there are a number of patients who will have, synchronous MRI metastasis at that time. Treatment for early stages is mainly surgical. Stage 1 and 2, surgery, as you saw, is usually curative, with a melanoma specific survival in the 90s. It's important to do what we call a wide local excision. that has large lateral margins. While there is no clear guideline on the deep margins, a lot of our surgeons like to kind of go up to the fascia to make sure that they took the entire depth. Sentinel lymph node biopsy is done for any lesion that is more than 1 millimeter, or for lesions that are less than 1 millimeter but have adverse features. That is a high mitotic rate, which, as I mentioned, anything more than 0, ulcerated lesions, lymphovascular invasion, transected at the base, so your shade biopsies, because again, you don't know how deep that is, and in younger patients. So our surgeons will usually talk to the patients about these risk factors and offering a sentinel lymph node biopsy for these risk factors. How do you do a sentinel lymph node biopsy? I bet you guys know from your breast cancer, maybe lectures, but I will explain a little bit. So every dermatome on the skin maps to certain lymph nodes. So basically what you do with a sentinel lymph node biopsy, that is done again after a biopsy found melanoma and at the time of the wide local excision. The surgeon will inject methylene blue and or radioactive substances in that area of the skin where you had the biopsy, and then they track it to see which lymph node will go to. The lymph node that the dye localizes or the radioactive substance localizes, those lymph nodes are removed completely and are analyzed under the microscope. Not only morphologically and with H&E, but also is analyzed with specific immunostains for melanoma, which allows us to diagnose even rare, or scattered cells, because those will now light up with your HMB45 marker, SOX10, etc. So all the other immunostains that are specific for melanoma cells. I want to mention here that sometimes, your melanoma is on the kind of, central axis. So if you have, central, on the trunk or on the back, can map to both sides. So surgeons have to pay attention to make sure that they capture both left and right axilla, if it's something in the middle of the chest or in the back. Or sometimes if you're in the middle of the back, midway through, I have had patients in whom it mapped, they had sentinel nodes in both axillas and both groins. So a good surgeon needs to be really, really careful in picking up all the possible sentinel lymph node locations. So what happens if you have a sentinel lymph node biopsy positive? Well, in the past, prior to a trial called MSLT1 and 2 especially, if you had a lymph node, a sentinel lymph node positive, the surgeons would go back in that lymph node basin and remove all the lymph nodes, or what we call a complete lymph node dissection. Now, that's pretty morbid on the patients, removing a lot of lymph nodes, a lot of lymphedema, delayed surgical healing, etc. So some surgical trials looked at, do we have to remove all the lymph nodes? So they stratified or they randomized, patients to have complete MSLT2, randomized patients to have complete lymph node dissection, or remove the sentinel lymph node and just observe that lymph node basin. It turns out that there wasn't a big difference in terms of, in terms of outcomes if you did or did not do a complete lymph node dissection. There was a small subset of, intermediate thickness ulcerated melanomas where there may have been a difference. But even in those patients, delayed removal of a relapsed lymph node seemed to be kind of similar in outcomes as if you removed it initially. So after this, trial, the surgical management of lymph node positive disease in melanoma has changed. Right now, we do not do any more lymph node dissection, but we go to sentinel lymph node biopsy. And then if positive, we, 1, give adjuvant therapy if indicated, and 2, we observe that lymph node basin. And I want to say that these results were actually reported for patients who did not even have adjuvant therapy, because a lot of the patients were enrolled prior to the availability of adjuvant therapy. So this is how this trial was designed. Now, actually, with the adjuvant therapy being so effective, probably the outcomes are even better. So we definitely do not need to do any more lymph node dissection. The way you observe the lymph node basin is both, with your imaging of choice, like a CT scan or a PET scan. But in this clinical trial, they also observed it with targeted ultrasound of that lymph node basin. So a lot of the surgeons will insist that we add an ultrasound to a PET scan. It is not very clear of how much value or more value that adds, but many of the practices, still kind of utilize both modalities to follow the lymph node basin. So as I mentioned here, this is just to reiterate that complete lymph node dissection is no longer recommended. So how about adjuvant therapy? Well, adjuvant therapy is both immunotherapy as well as targeted therapy for patients who carry the BRAF mutation. Adjuvant immunotherapy started with ipilimumab for many of the, physicians on the line. Dr. Jinga probably reckon, we know that we've used ipilimumab initially, and it was very, very toxic. We had 10 milligrams per kilogram dose that was, I don't know if I had patients kind of finishing all the adjuvant therapy doses for that dose. It was had a significant rate of immune-related side effects. So that, even though it showed kind of a survival benefit, now it's pretty much abandoned. We don't use that anymore, or at least we don't use it in the States. And now we use the anti-PD-1 therapies, nivolumab and pembrolizumab, which are approved for adjuvant treatment of stage 3 and 2, as I will show you in a minute, melanoma. Patients with BRAF mutation, the studies with dabrafenib and trametinib have also shown improvement in progression-free survival and in overall survival. And while I'm not going to show the curves in detail, you can kind of see here that dabrafenib plus trametinib, as well as immunotherapy, you can see a clear separation of the curves, right, in terms of percent patients alive without any relapse with both therapies. Now, here in the States, we don't use as much targeted therapy. We use it mainly for patients who do not qualify or are not good candidates for immunotherapy, maybe because they have autoimmune diseases or other contraindications, organ transplants, or patients who do not tolerate immunotherapy. We kind of offer more immunotherapy, or at least that's the practice here, at Mayo Clinic. And the practices differ in different, institutions. I was talking to a colleague from Yale, and they actually prefer targeted therapy. Both result in about a 50% decrease in the risk of recurrence. An academic kind of, reason for which we may not use it that much is that we don't know if this will induce some sort of resistance, for patients who later relapse, because we know that targeted therapy in stage 4 disease, most patients ultimately will acquire resistance. Again, this is not proven, I think, in any study, but we tend to reserve that for treatment of stage 4 disease. And when I discuss stage 4 disease, we can come back a little bit to this concept. So bottom line, both therapies result in about 50% reduction in risk of recurrence. So what does that mean? Well, if you look at, for instance, patients with stage 3, right? With stage 3C, this is a typical curve for a stage 3C. The difference between patients on adjuvant therapy versus patients who get treated. You see that patients, there is a number of patients, right, that recur despite of doing anything, and a number of patients that never recur anyway, because they, even with observation, they will not have disease recurrence. So it's a very small percentage of patients who actually truly benefit from adjuvant therapy, while we treat everybody because we cannot identify patients at higher risk to recur. And all have the risk of toxicity, and at least, here is significant cost for this treatment, as well as a burden on the patient. Regular clinic visits, regular infusions. So how can we get a little bit more of an idea who should we offer it or who should we not? It's important to start with the risk that they have to begin with. And that's why we individualize the risk for the stages, 2s and 3s. If you have, a risk of recurrence that, is about 50%, right, for a 3C, and you have a therapy that has a 50% reduced risk of recurrence, you kind of have an absolute benefit of 25%. So the number needed to treat here is low. So it makes sense to offer treatment, to these patients. If you have a stage 2A patient where the melanoma-specific survival is 90%, this 50% reduced risk of recurrence of an adjuvant therapy translates in an absolute benefit of 5%, which means you have to treat a large number of patients, 20 patients, to actually, have one patient benefit. So we really want to individualize the adjuvant treatment discussion based on the patient's risk. And again, we go back to staging and why it's important to properly stage the patients. Before, adjuvant therapy was approved only in stage 3, but now in the last few years, nivolumab is now approved for stage 2B and 2C disease as well. Why? Because if you see here, the melanoma-specific survival in stage 2Bs and 2Cs approaches that of a 3A or a 3B patient, as we talked about when we discussed the staging. So clinical trials with nivolumab were done in stage 2Bs and 2C patients and showed a similar, benefit in these patients. With a reduction in the risk of relapse, and now nivolumab is approved for adjuvant treatment of 3B and 3C. Now, there is a new kind of trend in melanoma where we are starting to think and consider and do neoadjuvant therapy, meaning treatment before you do surgery. And this is a practice in many other tumor types, is now kind of penetrating in melanoma. Why is it important? It's important because we think that if you do immunotherapy with a tumor in situ, in the body, it may actually, the tumor antigen is present, and it may actually induce a stronger and a broader anti-tumor immune response. Moreover, you kind of have a testing ground in the patient. You can give immunotherapy, then you remove the tumor, and you can see if the tumor is actually responding to that treatment. So how do we see that? We see based on what is called here the pathologic response. So in patients, some patients treated with immunotherapy will have a complete response, 0% viable tumors. These are the patients who now analyzed on this melanoma neoadjuvant consortium data. Patients treated with immunotherapy who had a complete pathologic response have had surgery, and as you see here, virtually 100% at the time of that follow-up were never relapsed. The next best thing is a near complete response, meaning 10% or less viable tumor. They tend to do pretty similar, 96, 97% continued response or recurrence-free survival. If you have a partial response, meaning you see a treatment effect, a number of melanoma cells that are not viable, but you still see anywhere up to 50% viable tumor. These patients also do well, but not as good as your complete responders, but not too bad either. They have a 90% plus recurrence-free survival after surgery. Now, the ones who do not respond you absolutely see no treatment effect, a lot of viable melanoma cells. These patients tend to relapse, after surgery, because of course you did not see a clear effect. Most responses we see if we use both anti-PD-1 and anti-CTLA-4. So the EP-Nivo neoadjuvant treatments showed, the most number of pathological complete responses and near complete responses. With anti-PD-1 alone, you still see, a number of patients who have these robust responses, but again, much less than with EP-Nivo, or at least this is from, the data available so far. So I'm going to go back to the slide that I skipped, and is what could be potential disadvantages? Why don't we do, neoadjuvant therapy in everybody, which, right now we're starting to offer it to almost everybody, is because there is this theoretical or this concern that what if patients develop, immune-related adverse events right after 2-3 cycles when it would be time to go to surgery? Why can maybe, then we cannot get them safely to surgery, or the results in a more complicated surgery, or what if the patients progress, in the first 2 to 3 cycles and then you don't get them to surgery? But this argument actually for me is if they progress, in the 4-6 weeks that you do, or 8 weeks that you do neoadjuvant treatment, those tumors were actually probably prone to relapse anyway, because most surgeries are not curative for cancers that are this aggressive. So there was one study recently published in the New England Journal of Medicine in 2023, the S1801 trial, which really randomized patients with stage 3 and 4 resectable stage 4 melanoma to undergoing upfront surgery, followed by adjuvant 18 doses 1 year of pembrolizumab, or start with 3 doses of pembrolizumab, do surgery, and then complete your adjuvant treatment. And you see here that there was a significant benefit for the neoadjuvant group compared to the adjuvant group. Meaning, just the fact that you did 3 doses before, you didn't change any treatment, did not add any drug, but you just changed the order or gave a few doses before, resulted in an improvement of event-free survival for these patients. Now, this is now in the guideline, and I'm part of the NCCN guideline panel, and we discussed, extensively. Definitely, now neoadjuvant is part of the potential recommendations, but we would love to see, the studies definitely reproduced in other studies or these results. The one thing I'm going to also say about neoadjuvant therapy is that you cannot accurately assess the response either clinically or radiologically. We had a number of neoadjuvant trials open here, and I had a number of patients treated, and we do immunotherapy, and after 2-3 cycles, some present with this enlarged lymph nodes and or tumors, really look inflamed, red, and you don't know, is it just a melanoma that looks, this angry, or is it an inflammatory response? Virtually all my patients who presented actually with this enlargement had a significant and robust treatment effect, a lot of inflammation in the tumor and of the lymph node. So while it's very scary, in those two, and the protocols go anywhere between 2 to 4 cycles, in the neoadjuvant setting, it is very scary. You cannot really also depend on the radiological response because it's discordant. So it has to be really a case-by-case analysis as to when do you abandon that neoadjuvant course and send them to surgery. The new trend, which again is not really answered yet, but was presented by the Netherlands group at ASCO, is if they have this robust response, do we need to do anything after that? And they actually, the Opposite trial looked at after a CR or almost a PR, patients did not undergo extensive surgery, and then they didn't give any more treatment. They only gave treatment for patients who are non-responders, lymph node dissection, and adjuvant therapy, where they actually added radiation to adjuvant therapy because these patients clearly did not respond to immunotherapy initially. And they are starting to analyze the outcomes. Initial results suggest that these patients here with a complete response or a partial response may not need any therapy, but this has not made it yet in the guidelines, of course. We're still kind of, completing the treatment, but it's probably a subject that will continue to evolve with more data accumulating. So let's talk a little bit about advanced melanoma, and I'm kind of running out of time, but I think this was important to discuss because it's a lot of, fine tuning with stage 3 disease. Now, in the metastatic setting, the big concepts are that you want to see if the disease is resectable. If you have oligometastatic disease that can be resected or treated with other forms of local interventions, SBRT or radiation, stereotactic radiation, or TVAC if there are subcutaneous lesions. If you can, and you can render the patient NED, no evidence of disease, you may offer, or we always offer, an adjuvant treatment, just like we would do with patients with resected stage 3. Now, if you're not able to resect the disease, or you have wildly disseminated disease, then you go to your systemic options. Patients with brain metastasis really require a multidisciplinary consultation because they may have surgery, radiation, or other forms of systemic treatment. Systemic regimens that are preferred is our combined, blockade with nivolumab, ipilimumab. We have the longest follow-up with this data, which I'll show in a minute, suggesting, a great response in stage 4 melanoma. Nivolumab and relatlimab is, or Opdualag is now available. And then the anti-PD-1 monotherapy. And I will discuss how we choose between those in a minute. Targeted therapy for patients who have BRAF mutation or combination of targeted and immunotherapy. I'm just going to say here that while in the NCCN guidelines, the vemurafenib, cobimetinib, and atezolizumab, is mentioned for patients who are BRAF positive, the results of this trial really were not reproduced by other combinatorial targeted and immunotherapy, and it is fairly toxic on patients. So it's not something that is very much favored by a lot of the clinicians. Tumor infiltrating lymphocyte therapy, lifileucel, is now FDA approved in the United States. And actually, I have my very first patient undergoing lifileucel now in the hospital. She's on day 3 of chemotherapy. She's a 17-year-old patient with a toe melanoma, and that's all we have left. So I am praying every night that she will be my first success story. Overall survival in advanced melanoma has evolved a lot. From a disease that had 1 year or less survival, we have now gone to the point where 50%, half of the patients at 5 years are, alive with, treatment, especially with combinatorial therapy. And we seem to have reached a plateau here. So hopefully these treatments are durable. Less patients with anti-PD-1 alone, but still a decent number. And the lowest number of patients alive with targeted therapy, around 30%. And again, this is because of that concept that a lot of the patients with targeted therapy will ultimately acquire resistance. So options, as we mentioned, are, the combination therapies. Now, how do we choose between them? Now, what when I see a patient, kind of how I go through the mental exercises. If the patients have very low burden disease, lymph node, maybe minimal lung or skin, is, anti-PD-1 still appropriate? Yes, possibly, especially if the patients are more frail. The objective response rate is around 40% for, patients with lower disease burden. And here it's important that these patients have the lower rate of adverse grade 3 to 4 adverse events, around 50 to 20%. Now, ipilimumab and nivolumab has the highest objective response rate, but also the highest rate of adverse events, right? About 50% of patients will have grade 3 to 4. It's really appropriate in patients who have higher disease burden. Alternative dosing with a flip dose, we call it IPI, or we do ipilimumab 1 milligram per kilogram and nivolumab 3 is also kind of available. There was a non-inferiority trial, but it was just one study. Again, the dose in melanoma, as opposed to other tumor types, is ipilimumab 3 milligrams per kilogram and nivolumab 1. And this is where we have the data that I will show in a minute. Relatlimab is moving more in the first line, because it has a fairly similar adverse event rate like nivolumab and kind of a little bit better objective response rate. TVAC or oncolytic viral therapy, we mainly use it if the lesions are injectable. And honestly, I only use it for 3B, 3C, maybe 4As with only skin and subcutaneous, metastasis. TVAC doesn't work at all in visceral disease. If they are BRAF mutated, targeted therapy, and now lifileucel. So we'll go a little bit in more depth, on these. Checkmate 067, our ipilimumab nivolumab trial, has the longest response, the longest follow-up. Again, a response rate, overall response rate close to 60%, with 23% of patients having complete responses. 1 in 5 can achieve a complete response. And another, another significant or 12% patients that have stable disease in addition to this 58%. And you see here, the numbers with ipi alone or nivo alone are much lower. The, as I mentioned, the follow-up, at 72 and 78 months now, so basically, 6 years plus, tells us again that we tend to, or we almost maintain that plateau. Remember when I told you 52% of patients are alive at 5 years? Well, we only decreased, by, a few percentages, with continued follow-up. So suggesting that the responses with ipi-nivo are durable and robust. Same with patients who are alive and progression-free. So 34% of patients on ipi-nivo at 6 years plus are still progression-free. Important to know here, the reason I put this slides is that we often think that patients with liver metastases in melanoma are a lot more immune suppressed, and the immunotherapy or treatment doesn't work, or the environment in the lesion, not the patient, the environment in the liver is more immune suppressive, and that's why the immunotherapy doesn't really work that well. Actually, with nivolumab and ipilimumab, if you see here, still, 38% of patients are, have responses and are alive, even with liver metastasis, which is lower than without, but still a significant number. So I wouldn't abandon the fight. This is to show that regardless of BRAF mutation, patients respond, to immunotherapy, and actually the BRAF mutated patients tend to even have a more robust response than the BRAF wild type. And this is important because now, even if you have a BRAF mutation, we do not treat with targeted therapy in the front line. Basically, the DREAMseq trials and other trials have shown that if you have a BRAF mutated patient and you randomize them to start with nivolumab and ipilimumab and then transition to targeted therapy when they progress on immunotherapy, or if you randomize them to start with targeted therapy and you put them on immunotherapy when they progress on targeted therapy, these patients that start on targeted therapy followed by immunotherapy at progression have a lower survival and a worse outcome. So regardless of the presence of BRAF mutation, we offer everybody in the first line, if they're candidates, immunotherapy. Now, what happens if they have a lot of tumor burden, which are a lot of my patients? They are so sick and progressing so fast that you really don't have the time to put them on, ipilimumab, nivolumab, and wait for that to work. Well, this trial, Seconded trial, told us that if you have these patients with high disease burden and you start them on targeted therapy and encorafenib, binimetinib for 8 weeks, enough to debulk them, and then you switch them to ipilimumab, nivolumab, but before they progress on targeted therapy, and then you put them back on targeted therapy only if they progress to this, patients in arm C, they actually did almost as well, if not better, than patients who were in arm A started, better than patients in arm A who started on Encobini, and almost similar to few percentages lower than your kind of gold standard if you are able to start them on immunotherapy first. So for me, again, to put this in again in kind of a summary, if they have a BRAF mutation, I start them on ipilimumab and nivolumab first, but if they are rapidly progressive, I put them on encorafenib, binimetinib, and then for a few weeks debulk them, then switch them to immunotherapy. This is to show that ipilimumab nivolumab has also an intracranial activity. Patients with brain metastases, these are smaller metastases in this trial. Patients are with large, bleeding, but patients with less than 3 centimeter metastasis on ipilimumab nivolumab without radiation, a 51% intracranial response rate. Nivo, again, lower than this, and these are your leptomeningeal disease patients which have very low responses. So ipilimumab and nivolumab also active in brain metastasis, and a lot of these patients who have a good response, the one who have a CR, tend to actually remain disease controlled even in the brain. With a PR, less likely, usually require a re-intervention. And same with the progression-free survival. So I'm only gonna say about relatlimab and nivolumab. You know that this is another immune checkpoint, and now the combination of nivolumab and relatlimab shows a better progression-free survival compared to nivolumab alone. And also for overall survival, the updated overall survival really did not show any, made a statistically significant benefit. You see here the confidence interval crosses 1, but the absolute numbers, are better by about 10%. So now relatlimab and nivolumab is, beginning to be used in first line for patients who do not really need quite ipi-nivo, but need a little bit more than single agent anti-PD-1. Targeted therapy is used in patients with BRAF mutations. We block both the BRAF and the MEK to be able to create a full, inhibition of the pathway, and this is better than either agent alone. What we know is that responses with targeted therapy are usually rapid in about 70% of patients, so you can count on them on these drugs, and quick. But most patients, or at least 60-some%, 70% of patients would ultimately acquire resistance. The long-term responders are your very favorable prognosis patients, normal LDH, just a few metastases. Those are the ones who tend to maintain the response. So as we know, so as we talked about, it's important to use these kind of in when you really need them. We have the encorafenib, binimetinib, dabrafenib, trametinib, and vemcobi available. I very rarely use this combination. Vemurafenib doesn't have a good, or at least we think, doesn't have the best brain penetration, or it's not very reliable. The only trial showing brain response is dabrafenib and trametinib. So I use dabrafenib and trametinib when I need something to also control the brain. But encorafenib and binimetinib have the best outcomes, the highest response rate, CR rate, and I usually use preferentially this regimen if I can. The best overall survival, as you see here, and similar grade 3 to 4 toxicities as vemcobi, maybe a little bit more than dabrafenib and trametinib. We do see a higher rate of potential bleeding, significant bleeding with encorafenib and binimetinib. So I'm really careful to not use this for patients who have bleeding, melanoma metastasis at the outset. So as I mentioned here, now how we think about frontline therapy, BRAF MEK, really sick, rapidly progressive, start with this to debulk. PD-1 single agent, really your patients with the worst performance score, your 80-year-old who barely can walk and they have, maybe like low or moderate, disease burden. I don't see why I need to put them on ipi-nivo or even nivo-rela. Those are my patients, less and less, that we use this. Nivo-rela for everybody with kind of medium disease burden who do not quite need ipilimumab and nivolumab, but ipi-nivo remains for high burden disease, liver metastasis, brain metastasis, because this is where we have the data. We don't have similar data with nivo-rela yet. Toxicities, I want to maybe I'll skip over this because you probably know a lot from your other tumor types, but I wanted to talk a little bit about lifileucel. Lifileucel is really a new form of therapy, is tumor infiltrating lymphocytes. Those therapies are made by resecting a tumor site. It has to be at least 1.5 centimeters or best between 1.5 and 4 centimeter tumor with any of the sites, shown there, but it has to be good, not necrotic tumor. If this tumor is resected, is sent to the company called Iovance, and they make this cryotherapy, cryopreserved product. It takes about 4 weeks. When you receive the product at the site, you put the patient in the hospital and start non-myeloablative chemotherapy, cyclophosphamide and fludarabine. Idea is to kill all the immune suppressive cells, potentially some of the cancer cells. Melanoma is not very responsive. It's mainly about the immune environment. So when you give this still, therapy, these lymphocytes now have access to the cytokines in the body, and kind of you decompress, the immune environment, they can grow. Then after chemotherapy, 24 hours later, you give the infusion. It's a one-time treatment. It comes in a number of bags between 1 and 4, depending on how many cells they were able to produce. And the way they produce this, again, they take the lymphocytes out and then they grow them with IL-2 so they can proliferate. So anywhere between 1 to 150 billion cells, depending on the tumor and the patient. And once you're done with the lifileucel, you give them 6 doses of interleukin-2, a high dose, 600,000 units of interleukin-2 we do it every 12 hours. So mainly kind of you see this is kind of a mini bone marrow transplant in a way. It's a very, potentially toxic therapy. So right now we're kind of doing patients who are very robust, clinically, until we get a little bit more clinical experience with this. It's important to know that even in the objective response rate, kind of a pooled objective response rate with the lifileucel is in the 35 to 40% of patients, even those who are progressing on PD-1 or ipi/nivo. So it can actually cause a significant response even in your progressors. This is to show that about 80% of patients have some reduction in tumor burden, that the responses happen very early in most patients. By 6 weeks after lifileucel, if they responded. And again, the responses can happen both in your progressors or primary resistant patients to immunotherapy. The median duration of response is not reached yet, and the median overall survival with this in the pooled analysis, 17.4 months. The side effects are really the ones of interleukin-2 acutely, during the hospitalization listed here, and the side effects of chemotherapy. If those resolve and the patient are discharged, usually there are no long-term side effects. So I am over the time and I am so sorry. I guess I was very optimistic on how I can finish this, but I'm willing, you're welcome any questions from you guys.
Mulțumim foarte mult. A fost o prezentare absolut fabuloasă. Apropo de noul tratament cu TIL, Rosenberg discută despre TIL de mai bine de 30 de ani.
Exact.
Acum tratamentul costă 515.000 de dolari. TIL.
Da.
Adică, I don't know, deci pentru Statele Unite poate că se va putea face în anumite cazuri, dar pentru țările europene, ca să dea un tratament de $500.000 de dolari, nu știu ce să spun, știi? Și asta este un aspect, să spun aspectul financiar, dar al doilea aspect este aspectul ăsta cu interleuchina 2 în doze mari.
It can only be done really in, specialized centers, right? Where you can have access to ICU and a multidisciplinary team. So financially, maybe it will evolve the way ipi/nivo evolved. Maybe the company will kind of, I think they have to, the price has to be, different in US compared to, Europe, and probably a lot of the clinical trials may open,
Right.
but it is a therapy that may not be available to everyone.
Yeah.
Mulțumim mult de tot pentru prezentare, ca întotdeauna prezentările tale sunt excepționale și sperăm să te auzim tot mai des. Mulțumim Dane, mulțumim Roxana, mulțumim mult de tot. Excepțional.
Și noi.
Excepțional.
La revedere.
La revedere și mulțumim mult, Dan.